Aloha. My name is Roger Jelinek. I'm Executive Director of the Hawaii Book and Music Festival, and welcome attendees, and welcome to a really wonderful panel. I think you're going to have a most interesting time. And without further ado, I'm going to turn this over to Brittany Lyte from Honolulu Civil Beat, who will be moderating. She's an expert moderator. Aloha.
Thank you, Roger. Hi, everyone. Thank you so much for joining us this afternoon for a conversation on the theme of pandemic isolation and a surge in eating disorders. My name, as Roger said, is Brittany Lyte. I'm a reporter at Honolulu Civil Beat. I live on the North Shore of Kauai, and I report on a wide range of topics, including mental health and social issues, with a geographic focus on our neighbor islands. I just want to thank all of our attendees for joining us today, and I'd love if you could type your name and where you're from into our chat box so we can see who's here. And during this presentation, if you have questions for our panelists, as you think of them, please drop those into the chat box as well. I will reserve the last 15 minutes or so of our hour together for your questions. So as they come to you, drop them in the chat. Our panelists this afternoon are psychiatrist Dr. Adam Coles, registered dietitian Liz Kaoh, eating disorder recovery coach Sarah Thom, and eating disorder specialist Anita Johnston. We will be discussing the impact of the coronavirus pandemic on people struggling with disordered eating and body image, cut off from daily social support systems like friends, work, school. Disordered eating behaviors have spiraled out of control during the pandemic, leading to a rise in the incidence of severe and life-threatening eating disorders. The good news, though, is that there is help available for those seeking hope and healing. I'm going to introduce our panelists now just a little bit more thoroughly. We have Dr. Adam Coles, as I said, joining us from Maui, where he is a general and pediatric psychiatrist. He is the medical director of Pono Maui, a residential eating disorder treatment center, as well as a psychiatrist for the Hawaii Department of Health. Before attending medical school, he was a practicing architect. We also have Liz Kaoh, a registered dietitian with graduate degrees in psychology and human nutrition. She concentrated her studies in psychology, on mind-body therapies, and in nutrition on regenerative farming. After working in oncology for several years, she began offering nutrition therapy for eating disorder recovery. Liz currently works with Pono Maui at the residential level of care and offers outpatient support through her private practice, Regenerative Nutrition, in Kaimuki on Oahu. We also have with us today Sarah Thom, a certified eating disorder recovery coach, who is the founder of Holistic Eating Disorder Recovery Coaching. As a coach, she provides a unique skill set cultivated from her own recovery and development of holistic practices focusing on body, mind, and spirit. Trained by Carolyn Costin, Sarah has created a therapeutic approach that is comprehensive and effective. Last but certainly not least, we have Anita Johnston, a certified eating disorder specialist and supervisor. She has been working in the field of eating disorders for over 35 years with multiple publications in professional books and journals. She's also the author of Eating in the Light of the Moon, which has been published in 7 languages. Johnston is the co-founder and executive clinical director of the Pono Eating Disorder Residential Program on Maui and Virtual Intensive Outpatient Program in Hawaii. She created the Light of the Moon Cafe, an online platform of support and education for disordered eating. Thank you so much to our panel. We have so much expertise here, and I'm really excited to dig into this conversation. So panelists, let's start with the basics. can you just tell us, so that we're all on the same page, what qualifies as an eating disorder? What are some of the most common types of eating disorders? And how common is it to have one? How prevalent is this?
Well, great question. It's funny, there's that moment of pause, like, who's going to jump in? You know, I remember asking that same question when I was in training. And I think that actually the understanding has evolved over time. So if folks don't mind a teeny little bit of looking backward, I remember a mentor of mine had a very kind of weight-based thesis about eating disorders, who trained me early on in the hospital-based treatment. And he said, well, basically, if they're underweight, you might be in anorexia territory. And if they're normal or overweight, you might be somewhere else. And that was sort of the very first answer that I got. And I think now we really sort of understand things in a little more nuanced way. And I think everyone should share, but I mean, how I think about these things is like we think about other disorders, not just mental health disorders, but other medical disorders, is there a pattern of behavior, meaning one's relationship with food and one's sense of body and body image and sense of self, that interrupts one's daily life or interferes with one's function in a significant way, such that it messes with your ability to enjoy life and seek out, your goals. And that can mean that it occupies a lot of your thought, but maybe you don't necessarily have a lot of external behaviors that are visible to others, but you might be thinking about food all the freaking time. So I wanted to sort of put that out there as a kind of more broadly based way of thinking about these things, so that we don't get lost in the peeling apart, what's anorexia, what's bulimia, and so forth. We can definitely talk more about those things, but just wanted to kick it off with that kind of idea of these are processes that interrupt our lives.
And I'd like to add that to really broaden it is if you can look at it as a continuum. So maybe on one end, you'd have what I would call eating difficulties. And then on the other end, you have severe eating disorders. And then you have disordered eating in between. And people can move around on this continuum. And not only that, but they can move around in terms of diagnoses. So someone might start off restricting their food and struggle with anorexia, and then maybe some part in their recovery journey find themselves binging and purging or getting caught up in exercise addiction. And then maybe later on in their lives find themselves in the grips of a binge eating disorder. So they're fluid. It's not like there's static things that someone is. And I like to say that that's not someone's identity. Someone struggles with an eating disorder, but that's not who they are.
I agree. And I'm really glad you brought that up in terms of the fluidity, because we were discussing before the session began, how uncomfortable even seasoned clinicians who work in other aspects of mental health are made uncomfortable in the world of eating disorders. And I think that's part of it too, is that change, that fluidity. We, like psychiatrists anyway, like things concrete sometimes. We want to say this is major depression or this is bipolar, even though actually people can evolve that way too. But yeah, in eating disorders, I think there is this capacity to shift the behavior and the internal experience so that you look like something else. And it's just because of how we've had to kind of codify these things, for our own trying to make sense of it, as well as other reasons, medical billing and so forth. We've had to kind of piece them out and call inability to take in enough calories and maintain a healthy weight. We call that anorexia. And, different patterns of behavior, such as purging food and trying to compensate for calories in. We call that bulimia, but it is much more fluid as we work with people long term in our residential care. It can change, and it confuses confuses us sometimes.
Mm-hmm. Yeah,
I'm going.
Oh no, go ahead, Anita.
You go, Liz.
I was going to say, I was going to mention, this idea, especially in this culture that we live in today, where we live in this very wellness-centric society, I believe, and we have, what we term orthorexia is this really high fixation on eating healthy and healthy foods only. And it's hard for people, I think, to piece apart, like, when does this become an eating disorder? And I think Dr. Coles had mentioned it too, was that sustainability piece, right? Like your social, emotional, physical health, if that becomes compromised over time, there's something that we have to look at deeper into, where is this really stemming from? Is there eating disorder prevalent here? Because it's really hard to piece apart, right? Especially in the culture that we live in today.
Yeah, because when you're working with eating disorders, you basically enter the world of paradox. Because on one hand, eating disorders are about food. They're eating disorders. But on the other hand, they're not about food. They're about things like, emotions and relationships, and it all gets tangled up together, which is really what the process of recovery is, I think, is untangling that. But it can be daunting for the person struggling, for concerned family members and friends, and for professionals as well.
Yeah, I agree. You brought something up earlier about how things have evolved in terms of treatment, away from kind of hospital-based treatment, more toward outpatient and residential care that's very therapy-based, which I think is a great evolution. And that how we experience, the behavior of eating disorders is an external expression of this internal process that's so key. And I like to think of it sometimes like, PTSD and trauma. We say post-traumatic stress disorder, but some of my colleagues, I'm not alone in thinking this, really prefer thinking of it more like post-traumatic stress reaction. And I bring that up because the behavior of one's relationship with food and one's body is often sort of experienced or witnessed by us as being reaction and coping with internal stresses and experiences that are too difficult to tolerate. And a lot of the process is to find out ways to work with those and cope with oneself, and to learn to be kind with oneself again, quite apart from the behaviors, that are just that outward measurable thing. But it's hard in a medicalized treatment model to get down into that.
Thank you. I feel like we have a really solid idea of what it is that we're talking about, which I just think is really important to start with. And so now that we know what an eating disorder is and sort of how it presents itself, let's talk about this totally world-altering thing that happened to us all, which is the coronavirus pandemic. So in the early days of the pandemic, especially, I'm curious to know from you, based on, the folks who you work with, how did people with disordered eating of anywhere on that continuum that we discussed, how was it for people who were trapped at home with an eating disorder? Whether it's mild or severe or somewhere in between. How did this sort of sudden isolation and the disconnect from support systems and familiar daily routines and this immense sense of uncertainty and fears around food shortages at the grocery store, would the barge come in, financial hardship due to job loss, all of these things and more, how were you seeing people who did have a difficulty with their relationship to food and weight and body image? How did you see that sort of settle into them? How are they reacting and responding?
Is rough. The folks I've worked with, I mean, consider if maybe you've been using eating behaviors as a coping mechanism, and as a result, it's been pretty isolating. And then you get even more isolated and not able to reach out in the same way that you used to. And so the eating behaviors would just exacerbate, because if that's your one coping skill and now you're in lockdown, the anxiety that can bring can be just exponential. And also for those that were in relationships and they're struggling with an eating disorder, there's no respite from that. If you're in the same house or apartment nonstop, and then there are those with children that they're having to care for, and they're having a hard enough time taking care of their own needs, and then they don't have the childcare support, not to mention the stress of financial issues. I mean, it just, in my experience, it was really, really tough.
I'd like to hear from Liz, actually, because didn't you still had outpatient level folks you were working with, right?
Yeah, and I want to say, I think we've all experienced the surge in demand for providers during this time. We could see like residential filled up, we added more beds, outpatient people, we have wait lists, right? And I think we've seen the studies. I think there was a recent study that came out that showed in adolescents, it increased 15% since 2020 to 2021. And that is highly underestimated, I think, too. I don't know if that seems underestimated, but you look at occupancy and inpatient admissions, it's like quadrupled since the year before the COVID pandemic, right? So it's really, I think at the outpatient level too, it's really a challenge. Primarily what I'm seeing is a lot of it in adolescents than I am. That just seems to me, from my perspective, a lot where the demand is right now, and especially finding people who are meeting people in person and having meals with people in a time when we're supposed to be masking, and we weren't sure if we could even see people in person, and doing virtual and how we can connect with people virtually can be really difficult. So definitely have seen an increase in demand and a need for it, a need for providers who are ED informed. Yeah.
And I've seen it from kind of both directions among the adolescent population and child, like down to age 9 here on Maui, which has been a really sobering experience, because even most clinicians who work in this field don't have a lot of experience with folks younger than like 13. And I think one of the challenges for young children who are struggling with this kind of thought process is really even understanding it, because developmentally they're still in the phase of life where they're forming their basic ideas still about food, about their body, about their identities in multiple ways. Gender and sexuality, they're just their core personality. So to be struggling with as fundamental and primitive, and I don't mean primitive like the people are primitive, but so foundational to a personality form as food, basic survival, has been really even more scary for us as clinicians, to work with, and their parents in this isolation and, service challenge. So, but on the other hand, we had folks with us during COVID in our residential facility. There was a whole other level of challenge there. And I'd love to hear from Sarah, like the experience we had at Pono during COVID, because it was interesting.
Yeah, I was just reflecting on that time, because I started working at Pono in January of this year. Before that, I had been working as a nurse in the intensive care unit. But what was happening is there was a lot of people reaching out because they were heavily struggling with their eating disorders. And I think that, when you're having eating disorder behavior, it is a very lonely, isolating thing anyway. But to have, the option of really not being able to see other people and having to stay at home and kind of being face to face with the triggers or things that are maybe not as helpful, I think that a lot of people just gave in. When I started working in January, it was interesting because it almost felt like people had somewhat of a community again. And they were getting a little bit of that physical support that the program was offering, because our residential is more so like people live there for a period of time. So I just know that seemed to be really helpful. And to have that in-person, face-to-face interactions, I think was really, really helpful for people that were struggling.
I agree. And I have to shout out to our own staff. And I sound like a shameless plug, but I think they did such a good job at keeping everyone safe, controlling COVID infection, episodes, and bringing people in and really making them feel welcome and safe, and like program could actually happen during the pandemic. Just a ton of work was done by so many folks. But the thing that we encountered, which I think a lot of people encountered, is even after things began to open up, folks tried to return to their lives, tried to reach out for some of those supports, whether professional or familial or friendships, and finding that many weren't there or had changed in some way. People had lost jobs, people had been forced to move, relationships ended, their therapist, their psychiatrist, their dietitian had moved or left, and so they sort of came out in this kind of post-apocalyptic world to try and reassemble their support system with even fewer pieces than our already strained system had to begin with. And I think that's the phase we're in now, is trying to put things back together with only half the pieces.
I'd like to speak to, I think a little bit of what you're doing, Sarah, because this is the new piece in the eating disorder field. Are coaches now that are stepping into the gap, because all the therapists I know, all the dietitians I know have waiting lists. They're full as a result of this. And so the idea of having coaches that are not therapists, but they can actually provide a great deal of support and are trained to do that, I think this is going to really help the situation as we get more and more coaches on board, because there's definitely a need right now that's still not being met.
Yeah, I agree. It's cool, and I want to kind of celebrate the hope that brings, because I think it's a level of profession and help that can be out there for folks. Another thing, that people can access to gain, traction on recovery. And so it means people who want to coach can go this different path, in training, even if they have another profession, even if they're a social worker or a therapist or dietitian. It's another tool you could put in your toolkit. I'm pretty excited about it too.
Yeah, I think it's been really helpful because coaches can stand a lot of times in the gap where therapists cannot. Like they'll go out with the patients, they'll eat scary things, they'll go clothing shopping physically with them, and then that level of accountability and having that support to be able to text somebody if you're really struggling in the moment, I think is extremely helpful. And I do believe coaching for eating disorders is somewhat, starting to pick up from the last few years. It's becoming a more defined role, but to have coaches that are actually trained and have done schooling in that field to be able to help with this, I think it's extremely helpful. And especially with a team, like a dietitian and a therapist, it's a really good support to have.
Yeah, so that's so fascinating, this sort of burgeoning role with a coach in this you know, in this landscape of treatment. And I'd love to just zoom out for a quick second and just talk about, you know, Hawaii's statewide doctor shortage. You know, it's a consequence of the state's high cost of living and limited medical training opportunities. And it's been a problem since long before the pandemic. I do have a little data here just to share. At last count, Hawaii had the equivalent of 2,857 full-time doctors across all specialties. But the state estimates it needs an additional 732 physicians to meet patient demand. Now that's down from over 1,000 in 2020. That's according to the most recent annual report that tracks Hawaii's medical professional needs, which is a great resource to be able to have that data and see what we're lacking. The greatest shortage is in primary care, with 163 doctors needed across all islands. But the system is also significantly strapped when it comes to mental and behavioral health. Of course, just the geography of being an island chain and in a rural, you know, state, mostly rural state, you know, these are all factors. So after, you know, having shared that, I'm wondering if we could talk a little bit more about how easy or difficult is it for people struggling with eating disorders to find and receive the appropriate care? Do you have to be rich? Do you have to live on Oahu, or like, you know, what's kind of the landscape? Basically, you know, is the infrastructure adequate?
You know, in some ways, COVID did open things up in that regard. So, for example, people on outer islands were really left with even fewer resources for treatment. And so when we moved to having a virtual intensive outpatient program, then that made at least that level of care was now accessible to folks that lived on Kauai or the Big Island, or places that they couldn't get, because prior to that, it was just Maui and Oahu. And so strangely enough, that has, in that particular area, it has provided more resources than were available before with the telemedicine.
And I think that's globally true, both in broadly medicine. I just had a televisit with a specialist last week myself, but in mental health, it's been critical. At the state level, we moved both our state subsidized services for families to all, you know, virtual, hybrid, or in person as needed. But it's still, in a raw sense, a numbers game. So I don't know if they got down to child psychiatry, for example, in the data you have, but I just reviewed this a few weeks ago, and you know, the numbers say that there are 7 child psychiatrists in Maui County. That's technically true in that 7 people who trained in child psychiatry live in Maui County, but not all of us are in practice. So 3 of them are actually retired, but still listed. So there's this problem, you know, and then the problem we all know about thoroughly in Hawaii is being an island chain. Most of the resources and most of the docs are on Oahu. And it has been good to see some of my clients in both these settings, in the eating disorders and more broadly in child psychiatry, gain access to psychiatry through virtual visits on Oahu. Even with folks that I've, you know, trained or worked with, we've been able to make that, you know, telemedicine referral, and that's good, but it's still just not enough people. And it's very hard to get trainees in medicine. You know, John Burns School of Medicine at UH Manoa, I think would like to train docs to work in the neighbor islands, but they need to go there and fall in love with the place. You know, like people fall in love with Kauai and Maui and the Big Island and want to move and live there and become part of the community. And it's very difficult to do that unless you can physically go there. So we need, if folks want to help, we need residents to come out to the neighbor islands and train out here and become part of the community and say, yeah, I want to keep serving this community. Otherwise, we're not going to get people to move, except from the mainland, but they mostly come and stay for a little while and then leave again. But yeah, telemedicine has been a game changer for us.
Yeah. I also, I think just from my own perspective of trying to help families navigate finding a physician or a PCP that's eating disorder informed and also practices weight inclusive, practices. That's been really challenging. I want to say that there's far and few, I think, that are aware of how triggering seeing someone's weight can be at the doctor's office, are trained in doing blind weights, making sure that the language they use around bodies and is neutral. And I think that's always been a really key thing, is finding people like Dr. Johnston had mentioned earlier that, Dr. Coles is like, you're this anomaly. To be able to have you with us at Pono is really amazing. And I think it's really difficult, though, to find amongst the shortage someone that is also eating disorder informed.
So let's talk about recovery. What does recovery from an eating disorder look like? I imagine it's different depending on the person and the circumstances, but broadly, what are the steps? If there's someone out there listening to this and they're thinking, okay, I think I have some questions about my relationship to food or my weight, or I have some concerns there, what are your first steps? What do you do? What does recovery look like? And is it possible to completely recover?
Well, I'd like to speak to the complete recovery part because I've been doing this for 35 years and I actually have seen thousands of people totally, completely recover. And I mean recovered, period. And it may be someone that's been struggling their entire life, or it may be somebody who has just started having a diet gone awry, or maybe it's somebody that couldn't ever be comfortable in their body. And whatever the range is, I've seen total, complete recovery. And so that I know for sure. I know that it's possible. And what it looks like, though, it's interesting because I think the word even is a misnomer, because recovery isn't going back to the life you had before you had all these struggles with food. It's a transformation where you step into actually a world beyond your wildest dreams. And what I mean by that is it's often difficult to imagine a life outside of the eating disorder, but that is where someone is headed when they choose to go down that path. And it's not always a straight path. As a lot of people take the scenic route, right? I mean, there's skills that have to be learned and insights that need to be developed. But so it's not an easy path, but I have to say it's absolutely worth it.
I agree, and it's been a learning process for me. Much of it from Dr. Johnston, but it can be revelatory in a slow motion sense. Sometimes it's like a lightning bolt, but it's that kind of super chipping away, working super hard kind of revelatory experience where you are a being, afterwards. But the first step, to me, like many things, medical and psychological, is to somehow gain the awareness that something is wrong. You have to recognize that something's not right. And I want to go back to something that Anita said a little bit ago, that eating disorders can feel like a little bit like backwards world. And one of the key pieces of that is that the symptoms, which are the internal and the outside behaviors that we see, the internal thoughts and the outside behaviors that we see, we say are frequently egosyntonic, which is sort of just fancy language for it. It's actually calming and feels good to a person who's in the grip of an eating disorder, and relieves distress and some of these other thoughts and feelings that are intolerable. Whereas the feeling of, depression, the experience of anxiety, the dissociative and other scary symptoms associated with trauma and PTSD are experienced ego-dystonically. They're painful and people don't like them and they want to seek out help. That's one of the main challenges and hurdles in folks seeking help or helping folks to seek help in eating disorders, is getting past that. I'm fine with this. I like restricting. It makes me feel better, into the perception of this is long-term probably not great, and there's something else going on here that's not healthy for you. And then internalizing that, like, okay, yeah, I'm in a space that is not sustainable. Speaking to that sustainability piece earlier.
And it doesn't help that we live in an insane culture right now that is just our language. I mean, when you see someone, you say, "Oh, you look great, you lost weight." I mean, it's everywhere you turn. We are steeped in diet mentality, and it's become normalized. Like this is a good thing to be obsessed about what you're eating and what your body looks like, and this is how we bond. We talk about what we're doing with our latest diet, or I mean, that doesn't make it any easier for someone who's in the process of recovering, because you have to find ways to insulate yourself from the barrage of messages coming from, sometimes it's family members, sometimes it's the media, but it's everywhere.
Yeah, and awareness is king. If you have another hour, Brittany, let's talk about diet culture. It's amazing, and it's so deeply set in the consciousness. So we're working with some folks in a foundation to help us at Pono, do some education and access help and stuff like that. And even some of the folks who are working with us are using language like, well, yeah, we should send the message that it's okay not to have a perfect body. And I say, okay, let's turn that around. Let's look at that statement, because that's so loaded with everything that's sort of horrible in our culture that generates this kind of stuff. The idea of a perfect body, that a therapeutic thought about eating disorders is that it's okay to not have a perfect body. And I want to get underneath that, and always underneath the next layer of totally distorted thinking about our bodies. But it's really, really difficult. And I think as therapists, our main job is to raise clients' awareness, their consciousness of the unconscious thoughts and distorted ideas that we're all soaking in, to really take a step back and see it all for what it is. It's one of the most difficult things we do, I think.
Mm-hmm. Yeah, I kind of want to add on to that too, like just the way that diet culture has sort of made its way into like the wellness industry and the wellness market, right? And I was shocked when I had found this out, but it was estimated that the global wellness industry market is valued at $1.5 trillion. So it's a booming industry, and that's projected to grow even more. I think that's even underestimated from what other companies had seen, like 4.4 trillion. So it's really definitely, we look at sort of how this plays into consumer behaviors and marketing towards people, and the language that we use and the fear tactics that we use, right, to get people to buy into these products and this way of life and living.
I like to say, just on the recovery piece, I'm someone that struggled for decades with eating disorders, and I am fully recovered. And I know it's to me, recovered means you don't have thoughts. You don't engage in behaviors, and you don't have thoughts about engaging in behaviors. You're completely free from that part. And when I think about it, because I required treatment, and I actually was under Dr. Anita's care, thankfully, years ago, and that was the last care I've needed. But I look back at what made it a little bit different this time. How did I get better? And I would say after spending, a good 5 months in residential treatment, it took about 2 years still for me to completely be what I would consider recovered. And it wasn't like I woke up one day and was like, oh, I'm recovered today. It was more like I was feeling anxious one day, and I was like, realized that normally I would have all these thoughts about exercise or food, and I realized I couldn't remember the last time I had a thought. And I think that was kind of like, whoa, I'm really surprised about that. But I think the two things that made it different this time was after I left treatment, if I had a behavior, I looked at it in a way that was not judgmental. I was really curious about what happened, the why. My self-talk was very, very different. And the second part is reaching out to other people when that happens, or preferably before it happens. Having that ability to be able to do that was so crucial. And I think those are the two things that I did different, that maybe when I required this level of care prior to that I did not do that the same way.
I think you're speaking to something that I think is really important for folks to understand, is that you can't think your way out of an eating disorder. Most of the folks who struggle are really bright, and would have been done with it a long time ago if that were the path. It's really a path of heart. And so what Sarah's talking about is replacing the judgment with curiosity, and I would say compassionate curiosity, that really learning how to be inquisitive and to solve the mystery with an open heart. That is the way out. That's the ticket. It'll get you there.
Thank you
Yeah, I
for,
agree. And oh, sorry.
no, go ahead, Adam.
I really want to thank you for sharing personal experience in it, and that's something that I think is so important for all of us to kind of realize, that raising that awareness thing, right? Like, this touches all of us. Everyone knows someone, is someone, or is related to someone who is struggling with an eating disorder, whether they know it or not. Mm-hmm. Just statistically, that's a thing. And it touched my life too. I have a family member. I can't say who it is because I didn't ask them to bring it up to this meeting, but they're in recovery, and and it went well, and they managed to seek out care, ask for help, and so forth. But even now, they tell me that they know they'll never be completely free of the thoughts. Mm. It's something to manage, to understand, to live with, for the rest of their life, as far as they know. And I agree, you can't sort of math your way out of this. I think you can feel and understand your way out of it. And it's a path of understanding yourself, but that can be so terrifying.
Yeah, and so if you are somebody who is listening to this and saying, well, yeah, maybe some of my behavior is disordered around food and body image, or if you're a parent maybe and you're thinking, I'm concerned about my child. So where do you start? I imagine, although I don't know, that you don't just knock on the door of a residential treatment program that's probably full. I mean, what's the first step? You call your primary care doctor, or you seek out a psychiatrist, or what would you suggest for someone who has concerns or questions about themselves or a minor? Yeah.
Well, I'd like to maybe give an overview of what the levels of care are, and then someone can decide their entry point, because usually at the lowest level of care, that would be outpatient, where you would seek out maybe an individual therapist, or you might go see your physician if there's medical concerns, or work with a dietitian. Having a coach at that level can be helpful also, creating a team. And so that would be the ground level. And then if somebody needs more than that, more than seeing a therapist or a dietitian once a week, then there's the intensive outpatient level of care called the IOP. And that's where you would continue to go to school, go to work, raise your family. But in the evenings, they're typically in the evenings, usually about 4 evenings a week to get involved with an IOP, which would be about 3 hours in a group process where you get nutritional support as well as therapeutic support. Then the next level up from that, if that's not enough support, is what's called the PHP, which stands for partial hospitalization. And that's when you really need additional support, especially around eating. So that's where you would spend your days in treatment, and you would have at least 2 meals there, and then go home to your family or to your own home. And then if that's not sufficient, then there's the residential level of care, where that's where you would actually go and you would live in and get 24/7 residential treatment with therapists, dietitians, support groups, and medical coverage. But for some folks that are medically compromised, they have to go up even a higher level of care, which is the hospital level of care, where they will get medical treatment because of the problems created from their eating disorder. So I just wanted to kind of give that as an overview so people would understand at that point. But typically you start off at the lowest level of care, and let those eating disorder professionals there help you assess where to go from here. What kind of support is needed?
Yeah. I can say that I've had people come to me from different providers referring them, whether it be a physician. A lot of it has been through therapists as well. So those are 2 of the primary referral sources that an outpatient dietitian might get as well.
Thank you for going through that, Anita and Liz. I want to give people some tools that they can sort of take as they walk away from this conversation. Another related question that I'd love to ask you is, do you have any tips, any do's or do nots for someone who wants to approach another person about behavior that they suspect is disordered eating? How do you talk about this with someone? Should you broach this subject with someone? Are there anything that someone should know? Okay, make sure you don't say anything, that would trigger this, or here's a gentle way to approach it. Just how can you approach someone who might be struggling?
I think talking to somebody in a non-judgmental way about some of what you're seeing is helpful. Often, I don't know, I've been working with kids a lot, and often some of the things that parents can say that's not helpful is making comments about the body, presenting things in a way that might cause shame about the behavior. And I think just really having a dialogue with the person. I'm really concerned about this. This is what I'm seeing. And I know that we can get help. Is there a way I can help you? I think that could be really helpful. Instead of, again, not making comments about body or food or what they're eating, that kind of stuff is probably not helpful. Because it's not about the food, it's like very underlying, the issues. Sorry, Anita.
No, I was going to piggyback because I think the examples you gave of how to speak, it is to talk about your own experience, right? I'm concerned, and if I can help in any way, if that's helpful for me to get resources. So really, for the person to talk about what it's like for them to, without talking about the person's physical appearance, but what their concerns are, and it is really a good way to open the conversation. And of course, it depends on the level of intimacy. How close are you to this person would determine what you might feel comfortable saying. I think that the primary message is there is help available. And you don't have to go this alone.
Yeah, I think being, especially from the adolescent, focus, but for, everybody, really presenting oneself as a giant ear and non-judgy. Adolescents already are very sensitive to the experience of being judged by their peers, by their parents, teachers, kind of everybody, themselves. Really coming to that conversation in a very just sort of concerned, caring, listening, non-judgy way, and just expressing, hey, I'm a little bit worried, and don't want you to feel like I'm angry with you or making fun of you or anything. I'm just concerned. That goes a long way, because a lot of folks might want help but don't know how to ask or don't even know how to reach out, so giving someone permission to just express that they're hurting, and that goes for kind of everything, right? Substance abuse, mental health, medical health, all that, but 10 times for eating disorders. There's such a huge stigma, and there's so many reinforcing aspects going on around them, in the culture that we've talked about, and social media and everything, and among peers. We don't have time to talk about high school, but it's off the charts in high school. So really providing a kind of safe place to talk about it is job number one.
And adolescents struggling with eating disorders, this is a theme that keeps bubbling up. So, I just want to ask, are eating disorders more prevalent among certain ages or genders or ethnic groups? We've talked about stigma here, and, what I've perceived from the media and from my life experience is you associate eating disorders, however incorrectly and crudely, with, young girls. I imagine this is not something that only young women struggle with, but
you nailed pathology, right? Yeah.
So are these disorders more prevalent among certain folks than others, or is this something we're all equally susceptible to?
I would say we should recognize that everything is underreported. So that's one of the challenges. You can go and find numbers. We can report numbers, but recognize that they're inaccurate. Like Liz said earlier, dramatically underreported. So, and I didn't want to interrupt.
Yeah. Well, it's interesting because the new research shows that the two populations that are at the highest risk are adolescent girls and perimenopausal women. Now, again, this is with diagnoses of anorexia and bulimia. The binge eating, we don't really even have a whole lot of data on that because that is super underreported. But and it's also, in the beginning, it used to be, oh, those young white girls were getting eating disorders. And that's because that's where the research was being done initially with college students. And so, of course, all the results were skewed in that direction, but it is absolutely across all ethnicities, and actually all sizes. So the other thing is people assume that, only skinny people have eating disorders, and that is absolutely not true either. So this is something that people struggle with from across the board. It used to be primarily females, but that landscape is changing rapidly, and so we're seeing folks who are gender fluid, and we're seeing people who identify as male and identify as female, and it's basically nobody is free from having to be aware of this.
And I think it bears mentioning that there's the other side of that coin is who's at risk of being ill and undiagnosed. And so the male population is at the greatest risk of being undiagnosed and yet ill with an eating disorder. Both the identified and transgender, very high risk for all mental health entities, generally between 4 and 6 times, binary gender identifying population, but eating disorders especially, and
large bodies, people in large bodies.
Absolutely. And in the updated edition of his landmark book, Dr. Phil Mailer from the Acute Center in Denver talks about atypical anorexia, which is really an attempt to wrap our heads around and dispel the idea that anorexia has to look like an overly skinny person, overly skinny female person. And so we talk about this a lot in our team meeting at Pono, that there is anorexic thought process going on. And that's really the most important thing. We talk about weight loss velocity. Someone can still be in the normal weight range, but if they've gone from 220 pounds to 150 in a couple of months, well, that's a high velocity, and that's concerning. And so we're expanding our ideas of what this all means. So I would say, no demographic is free of risk. There was a mythology here too, locally, that, because of general body positivity culture in Hawaii, that there was a lower kind of risk profile. But that's turning out to be, it's either changing or it wasn't even really as strong, as everybody thought it was. It's probably a mixture of both, because, Western and the Eastern sort of diet and body culture, such as from South Korea and other, Southeast Asian countries, are really wending their way in here. Hawaii is such a melting pot. And I've gotten an education from my teenage daughter about beauty standards in Southeast Asia that have melted my brain and given me such fear. It's all coming together here in the middle of the Pacific. So we got our work cut out for us.
I guess, just to throw out a last question here before our time is up. Any silver linings of the pandemic? We did talk a bit about telehealth and maybe this new function of the coach stepping into this treatment landscape. Any other silver linings to this time we all would love to forget?
Well, one of the things we noticed, and this is, I think, why there was an uptick in people seeking treatment, is that people weren't able to go about things business as usual, and they had time to reflect on what was going on with them and chose to seek treatment. So I'm sure that the pandemic exacerbated eating disorders, but it also did give people an opportunity to reflect. And there were those that said, well, can't go to work, can't go to school, might as well get treatment. And that happened all over the place.
I've heard that so much, folks who came, through our doors.
Mhm.
I agree. And I think another silver lining is it triggered a lot of people to think about what is really important in their lives, what relationships are important, what's really meaningful to them. And a couple of people, not everybody, but a couple of people realized that without that gaze of others, there wasn't that sort of data coming in, of people saying, oh, you're so thin. And they really began to think about their own thoughts in a different way and begin to think about, well, what do I really care about? And I think that has been a kind of, and haven't we all sort of thought about what's really important in our lives, our work setting? Do I really have to be in an office? Is that like super necessary? What do I do for self-care that is actually meaningful to me instead of just binge watching the next show that I want to? Not that that doesn't have value, but I think that has helped some people to seek out some help.
Great. Thank you so much, Sarah, Liz, Anita, Adam. Nice to be here with you.
Thank you guys so much.
Thank you.
Well, Anita, thank you very much for putting this panel together. I thought it was brilliant, really caring and empathetic, and very positive. And I hope a lot of people will make use of this. It will be, it has been recorded, and it will be up on the Better Tomorrow Speaker Series YouTube channel and eventually on our website. And I would encourage you to use the link and send it out to your colleagues and to anybody who you think needs it, because I thought it was a really excellent introduction to the topic. And thank you, Brittany, for really excellent questions.
Absolutely. Thank you. The questions were so thoughtful. I really like learning more about everybody I've been working with for 4 years, things I didn't know. That's cool.
I have one more chore, which is we absolutely intend to be in person next October as a 2-day live festival. It takes a lot of funding. So we have a fundraiser on January the 26th. And I would encourage everyone to put it in their calendar. And I'll be reminding everybody endlessly about it. Let's meet again a year from now. Aloha. Thank you very much.
Aloha.